listening to the Agent Survival Guide podcast, a podcast for today's insurance agents. Informing, educating, empowering, improving the way you do business in an industry that's anything but static. In today's episode, we are exploring the connection between risk adjustment models and value-based care. Dr. Shannon Decker joined me to talk about recent changes to several risk models, what that means for the industry, the impact on our clients, and how agents should proceed. Here's our conversation.
Thank you so much for being here, Shannon.
Thanks for having me. Excited to be here.
First, before we get into our conversation, I'd like to get a little bit of a background on you. Can you give us your official title right now? And it's okay if there's more than one of those. And then just how you got your start in the industry.
Sure. So currently I am CEO of VBCOne. That's VBC. So for Value-Based Care One. We're your one-stop shop for fractional operations support. We're more of a boutique consulting firm, and we work with medical groups and health plans around the country, working on any needs that they have around risk adjustment, quality, and total cost of care programs. How I got my start in the industry, I started in healthcare in 2000. It actually was an interesting segue. I was a high school English and history teacher, but had a passion for fitness and was simultaneously competing in fitness competitions and was a fitness model, and thought, I'm really passionate about this. How can I use what I know about learning and motivation and what I know about fitness to help people live healthier lives? And so started working with a company called Envision Health and Wellness. And we would work with companies on how to mitigate employee wellness risk. So how could we help their employees be healthier? And the thinking was more productive. And then that segued into managing risk adjustment operations end to end nationally for HealthNet at the time, now bought by Centene. Did a stint at United Health Group, worked for Optum, and then several large medical groups across the country. So again, having sight into what goes into operations at the health plan level, as well as the risk-bearing provider entity. And then in 22, had an opportunity to strike out on my own. And so doing what I've done for years, I now do in my own company with my own team. And several of the folks that work for me have worked for me over the years. And so I know that I have the expertise that's needed to be able to help a lot of these groups that are trying to navigate these value-based care contracts.
You got into it a little bit there, but what is your specific area of focus now? And how did you really make that decision that was where you wanted to go?
I had this moment a few years ago, and I tell this story of, what is it that drives me to get up every day? Because I'm not someone that's necessarily motivated, by money or title and things like that. It was around how could I make a difference and how could I feel like I would leave a legacy? So what I'm doing today, I really feel like I'm improving healthcare. And we work with health plans, but I really enjoy working with physician groups across the country of how to improve and make sure that they're succeeding in these value-based care models. And I really think, when you think about value-based care, that if it's done well, the intent is to provide better care for the patient, better outcomes for the patient, because you're paying attention to what their conditions are. You're encouraging them to get their preventative screenings in a timely manner so that you can better manage their health. And hopefully, they won't follow the typical trajectory that you would find a patient who has diabetes. We know certain things about once you have a diabetes diagnosis, within 3 years, you'll have impact to your eyesight, if not sooner. And 10 years unchecked, significant impairment, visual impairment, and blindness. In my thinking, the work that we do encourages patients to get their screenings, to make sure that doctors are doing those screenings. And, that's just one example. But by doing that, we're improving outcomes and we're improving the health of those patients.
Now, can you give us a basic definition of a risk adjustment model and its purpose in the larger health insurance market?
Sure, I think so. I know it sounds very convoluted. When I think about risk adjustment, put simply, it is reimbursing or making sure that monies are available to care for those patients. And so every type of plan has a different risk model. And that's just come to pass because it was health plans and the government, right, trying to figure out what made sense. So Medicare Advantage is different than Medicaid. Medicaid is governed by the states. You have ACA, that's a different model. It's what we call population based. I promise I'm going to get simple. You asked me. But essentially, what it means is that you are given monies or you're given an allotment that the intent is that you're using those monies to pay for the care of those patients. Take, for example, and I'll use Medicare Advantage. I usually show this because I work a lot with physicians and I teach about how important it is to document those patients and to make sure that their health record accurately reflects the chronicity of disease that they have. And so if you take an 85-year-old female living on their own with no conditions, the reimbursement for that patient, meaning that we expect that patient to use the healthcare system in a certain way in a given year, and so the reimbursement for that patient might be $2,000. But a patient with diabetes, and we know diabetes is often complicated because, like I said, within the first year or so of diagnosis, patients usually have a complication that's associated with that. So if I took an 85-year-old female, more than likely, and I'll ask the doctors in the room too when I'm teaching this, I'll say to them, how many of you have this patient? No hands go up when I say 85-year-old woman with no conditions. But if I say 85-year-old woman with diabetes, and they also happen to have chronic kidney disease, hypertension, they have an ulcer, right? So all the things that we would expect that unfortunately accompany diabetes, and if it's not managed well, can be even more significant. The reimbursement for that patient could be upwards of $10,000. So significant difference. But the thing is we know that those patients, especially those ones with greater complications, need more care. They're going to go to the emergency room, unfortunately, right? But they're also going to see their doctor. They might have an inpatient stay. We know these things about these conditions that the majority of Americans have. And so that's what risk adjustment is. It's a way in which monies are given to doctors to pay them to do the good work that they're doing for those patients. And for health plans too. So to provide those programs, there's diabetes education programs, making sure that patients have access to particular medications and so on and so forth. So that's the intent of risk adjustment, is to provide those monies for the care that we know those patients are going to need.
Now, something that you mentioned there, you kind of mentioned those different diagnoses. And I know that we have talked about the coding changes that they've been making to different risk models on some of the past episodes of the podcast. But one of the interesting things that I saw in some of your talks and things that you had presented was that that's not necessarily the most important component of a risk model. So what are some of the other important components that go into that risk adjustment model other than the coding?
So when I think about it, and, I think that for a long time, the industry focused on one particular aspect, and it was get the diagnosis code and submit it. But if we really think about it, we need to raise the gaze and look across the horizon. And the intent is to create a better healthcare experience and to make sure that monies are available for the care for the patients that need it. The doctors are reimbursed for the time that they're putting in. And it goes beyond risk adjustment. It delves into quality, into total cost of care. But in the end, that's the thing. I think, we look at the tree when we think about codes rather than the forest, but we really need to look at the forest. And that is, how can we make healthcare better for patients and to make sure that people get the care that they need when they need it? When I think of like the codes and the changes, and the way I recommend or make recommendations to clients is focus on who the patient is in front of you. Document their chronicity I don't care if it risk adjusts. We shouldn't be thinking about that. It's not about that. And I think
Mhm.
that the focus in the past where people have put that, make sure that you document this or that, or be looking for this particular condition. I think that got folks into trouble, right? Because they were potentially documenting things that weren't appropriate. Or then, two, they were so focused on the documentation, the real focus. And I think this has been the impetus. I know it's been the impetus for all the changes with CMS and OIG and CMMI is focus on the care and the better outcomes. And so the follow-up care that's needed. So it's one thing to document that a patient has diabetes with all those conditions that I mentioned, but what are you doing about it? The money that you're being reimbursed is intended for you to invest in the care of that patient. And if you're not doing that, right, like you're not fulfilling all the steps that are needed in order to get to again, this larger goal of better healthcare, then you're doing a disservice and you're really not making anything in the end. So
That was very well said. And I know that we've seen some changes come through this year. We had the final rule come through, and there were a few different models that they're bringing changes to. Some are ending. So, can we look at those changes and some of the different programs and see what changes exactly are coming and what does that mean in regards to taking the change from the risk model, and then what does it mean for that value-based care ideology?
So I could go through all the individual changes, but I'm going to
Mhm,
try to keep it in a summary perspective,
mhm,
and then I'll talk about how it feeds into the larger program. And so when I think about some of the changes, and I'll mention a couple. So, like
mhm,
diabetes was collapsed. It
mhm,
used to be that you received a certain risk adjustment value for diabetes and then diabetes with complications. And the thinking was is that diabetes would be collapsed because there's kind of a saying in the industry that you hardly ever meet a diabetic that isn't complicated, right? That there's always typically some complication that follows quickly. And I'll use that as an example. So, and I'm calling off the top of my head, so I might not get it perfect. But if I remember right, diabetes without complications was like a 1.3 in RAF score in V24.
mhm,
V24 was the model that we were in prior
mhm,
to going to V28, which this today, date of service 2025, is solely based on what's called the V28 model for Medicare Advantage. So diabetes was uncomplicated, was about a 1.3 RAF score. Diabetes with complications, if I remember correctly, was about a 1.8. They collapsed it and now it's a 1.6. The thing is, you could focus on those numbers and
mhm,
think about the losses, but again, I wouldn't. I would think about what are the things that I need to do in order to be successful? And I'll talk about the three levers that I always talk about that you need to push on, and then my three-legged stool here in a second. But when I think about diabetes, there's the 1.6 RAF score, but what other people didn't account for is demographic value. So where you live, your gender, your age, all of those things go into the demographic value. So while 85-year-old woman might have been a zero point 0.4 before, the demographic value in V28 went up to a zero point 0.6. And then there were other things that were added into V28. There's something called condition count. So it is common that, in fact, I was reading a study the other day that was done in 2018 by the CDC, and it's 27%. And again, I'll have to fact check myself, but I think it was 27% of all Americans have at least one chronic condition. Think about
mhm,
that for a second. That's pretty significant. And then it only increases with age and actually with gender. So females tend to have more than males. And then it was over 60, the majority of Americans have two or more chronic conditions. And so knowing that in the V28 model, if you have more than one chronic condition, the condition count was added before, but it just got
mhm,
more, I think, more value to it. So anyway, if you are a patient and you have more than one chronic disease, it's 5 or above, there's other factors that get added into that. And
mhm,
then there's also something called disease interaction. So we know diabetes often occurs with hypertension or with, chronic kidney disease. And so those interactions carry RAF value. And so even though diabetes was constrained to the 1.6, You have all these other factors now that can be added in. In addition to that, and this came out just recently for 2026, right? So the rule that came out this year, the other thing is around prescriptions. And so there was some of that in the initial original final rule that we're working off of, but there were additional values that were added this year. And so that's another thing too. And what I'm advising even our provider groups to look at and to talk with health plans about is that there's risk value associated with the prescriptions that patients are taking. And so there's RAF value there. So the RAF model changed, but it doesn't mean, a lot of folks said, oh my goodness. And we do see a lot of health plans exiting the market and not quite sure how to deal with it. But I think that we will see in our near future some stabilization. And I think they just need to recognize that monies are there. They've just been shifted around. And so knowing how to place patients in the right plan and then making sure that they're accessing healthcare in an appropriate way is what's appropriate. And so I mentioned to you, when I think about value-based care, I mentioned this three-legged stool. When I think of this three-legged stool, it's not just about risk adjustment. Risk adjustment is after the fact. And again, the way V28 is structured, and the way the RADV audits that are coming out that the government is saying they're going to perform on all the health plans, you need to be thinking not just about risk adjustment, but what I was saying to you about quality. When I think about quality, the intent is to protect patients, to make sure that they're getting their screenings timely, to make sure that they're finding out about if they have cancer, right? That they're keeping their A1C in check, that you're able to provide all that education to hopefully keep them healthier longer so they don't get these diseases, or if they do get these diseases, that they're not getting as sick as they potentially could. And then the other leg of that stool is total cost of care. And that is, don't go to the ER, right, when you have a flu or a cold, but go to the urgent care or call your doctor's after hours line. There's more appropriate ways and places to take care of our health than to say, going and getting admitted to the hospital or showing up to the ER. And no one wants to sit there at 2 a.m. So yeah, using virtual care and getting the things that you need. So when I think about the models, I think V28 was really a shift in moving the monies around, but then also focusing on getting us to stop focusing on just cleaning up. That's how I think about risk adjustment. It's cleaning up after the fact. How can we really move it forward and improve health outcomes for patients and improve experiences for doctors? The other thing I was going to mention to you, and just with the models, I said the three levers. I always think in threes, but when I think about making a difference, I think about technology, so tools and technology that can be brought to bear, and then also to patients. What do we need to do to get them educated and engaged so that they're accessing healthcare appropriately? And then physicians, right? How do we work with our providers to ensure that they're doing the things that they need to be doing? And again, checking up on patients and, ensuring that they're getting their screenings and things like that on time.
So with those changes that are coming, what is going to be the impact on beneficiaries in some of these different programs? I mean, I know in the Medicaid arena, at least, we are going to be seeing a lot of people who are losing benefits, losing the ability to even be on Medicaid, probably moving forward. But what is the impact for Medicare Advantage or for Part D?
Great question. And like I said, I've been reading the One Big Beautiful Bill. I also have been looking, like I said, I had shared with you just some different articles that have come out that we've seen. There are payers exiting particular markets, right? Focusing on Medicaid now instead of Medicare Advantage. I had shared with you Aetna, it came out in Modern Healthcare. They're slashing, I think it's 990 plans, but the majority of them are PPO. And then I speak at conferences a lot. And so I have the opportunity to be at different venues and hear different leaders of what they're thinking. And when V28 first came out, the strategy was throw all the benefits you possibly can and sign up as many people as you can into the plan and we'll figure it out. And then the other strategy was, how could we get more specific and cut costs? I think what we're going to start to see is probably a hybrid of that. And so you'll see plans that are going to choose certain markets or models that they can operate in. And I think they're going to take a hard look at what they can offer. What I would say to folks that are working with beneficiaries and trying to determine what plans they should be in, I do think that we're going to see more special needs plans. I do think, you mentioned Medicaid. While there'll be a lot of disenrollment, there will be an opportunity for those patients or those beneficiaries to find care on the exchange, which may be more appropriate, right? And same thing with Medicare. There may be some that are, more aptly and appropriately placed in Medicare. But I think it's really understanding what serves the patient best. And I think that health plans, that was one of the other things too. Some of the changes were with VBID and some of the waivers were impacted. Some of the benefits that patients got in the past, CMS had come down and said, we really want to make sure that, if you're offering a food benefit or if you're offering transportation or a gym membership, that patients are actually using it and you're able to demonstrate that it's actually improving care. And again, right, there's a common theme here in our discussion is it's all about that end goal. How can you help patients get to better outcomes? So I think sitting with those patients, those beneficiaries, understanding what their needs are, what type of plan do they need if they have diabetes? And I do think we're going to see, especially because of what they call special needs plans and the ability to offer those, you're able to develop more comprehensive plans around particular diseases. And so taking a look at those, if they're more appropriate, and enrolling patients in those types of programs so that, again, they can better manage their condition. They have diabetes, be in a diabetes plan. If they have cancer, right, they should be on a cancer program. If they have hypertension, cardiovascular disease, they should be enrolled in those types of plans. And so I think it gives us an opportunity to find solutions that, while it may not have all the bright lights and bells and whistles with all the extra ads, it's going to have things that are meaningful that should make a difference and make it easier too for patients that have those conditions to get the care that's needed.
Right, right. And I think you got into answering a little bit of my next question there with, what we can as agents do as far as what is happening this year to help our clients if they are being impacted by these changes. It sounds a lot like this year is a lot more quality over quantity, that you're looking at the quality of the benefits that your
100%.
client is going to be getting rather than necessarily all of those different add-on benefits that they sound great on paper, but if they're not utilizing them, why are we including them? What else can we include that might be a little bit more beneficial?
You bring up a great point, and I would agree with you in what you said. And I have the greatest respect for, the space that the broker lives in and the relationship that they have with their clients, because they really have an opportunity. To me, that's the starting point and then carries it through. You have an opportunity to really encourage patients to get their annual wellness exam, do all the things that they need to do. And healthcare is difficult. I mean, that's one of my missions too, is how do we navigate this system? I've lived and worked in it for over 25 years, and I still have challenges when it comes to my own family trying to get through it. And so I think that the broker in particular is in a great place to help the beneficiary understand and navigate that space well. I also think too, I mentioned the Aetna article. One of the things that it said is that it was going to cut commissions to brokers if they sold those plans. And so that's how they were going to look to wind it down. And I think that there's been a lot of changes too from CMS around how brokers are compensated, how you can market. I'm not up to date on all the changes, but I know that there's been significant ones. And I think it just goes again to recommending what's appropriate for the patient, which I know brokers have at heart and do. And then in the event that there might not be a commission, but if that's the appropriate product for the patient, helping and working to find a way to get them into the right space. I think that takes working with those health plans, that dialogue, the continued conversation with all the parties invested.
Now, for agents who are interested in learning more, either about risk adjustment and learning about some of these different changes coming through, or interested in learning more about the philosophy behind value-based care, why value-based care is so important, what do you recommend for the ones who are kind of curious like we are, that, lifelong learners who love to learn more?
I love that. So you can follow me. My group, we do work with different entities, including brokerages, on educating them on changes. We have a newsletter that we put out. I also have a podcast. It's called VBCOne Take. So the intent is to provide one nugget related to value-based care. But again, we do education. And then also too, I am a prolific speaker. I speak for a lot of different organizations, but one in particular is my favorite. It's Rise Health. And they do offer several summits and even ones that are specific to brokers. And so I got to speak just in February. It was in Puerto Rico. I forget where it's going to be coming up. I think Vegas maybe. But they do a Medicare Marketing and Sales Summit, and they have a lot of events that are, all over the map for different folks that are working in healthcare. But I know that they do specialize in providing, sessions and whole conferences that are designed around brokers and beneficiaries. So I think that's something to look into too.
Okay. Anything coming up that you have going on that you'd like to shout out here on the show? Any appearances or anything like that you've got coming up?
Yes. So you can usually find me somewhere, maybe even a couple times a month. And then we always have things going on at VBCOne. We have different products and other things that are coming out. And so follow us on LinkedIn is the best way to get in touch with us. And you'll have free access, I should say, to our different materials. We're getting ready to launch a directory that will be, we have a component of it called OneWire that will be an industry news aggregator that folks will be able to access for free. And provider enablement solutions will be able to advertise there if it makes sense for their company. So,
okay. That sounds awesome. You can definitely count on me subscribing to the aggregator. That sounds fantastic.
Awesome.
Anything that you want to mention that you think we didn't get to here today, or anything that you feel super passionate about that you want to just kind of wrap up?
Thank you. I would just underscore some of the things that I had said already. I think that in the end, if we think about what it is that we're trying to do, what's the overall goal? And that's, again, to improve healthcare and improve outcomes, right? We want that not only for the clients that we serve, but for our parents or our children or, Aunt Mary, whoever, for ourselves. And so I think that if we remember that and keep that as the goal, and I know your listenership and the brokers that I've worked with in the past, that's what they want too. And so just keep doing the good work. You guys do amazing work on getting beneficiaries to sign up for the right plans. Continue to do that good work. And I think that with all these changes, they shouldn't knock us off course. They should help us get there faster. And I know that some folks want to roll around in the mire and muck of, there was a code change. But I don't think, again, that you can think of it that way. I think you need to raise the gaze and think of those long-term outcomes and continue to do the work, continue to do the good work that you're doing.
All right. I like your take on that. I like the concept of raise the gaze. Well, Shannon, thank you so much for being here and appreciate your insight. And we'd love to have you back sometime to talk with us again.
I would love to. Thank you so much. It's been very enjoyable. Appreciate it.
Special thanks again to our guest, Dr. Shannon Decker, for the interview. Be sure to check out the episode notes for links to the resources we talked about during our conversation. Also, in the notes, we have links to where you can find her online, the link to subscribe to her newsletter, and her social accounts. Thanks so much for listening to this installment of our Agent Survival Guide podcast. We will see you next episode. The Agent Survival Guide podcast is a production of Ritter Insurance Marketing, an Integrity company. Special thanks to Dr. Shannon Decker for the interview. Recording and production by me, Sarah Ruppel. Podcast design by Urban Rivera. Artwork by Tina Lamoureux. Like, follow, rate, and review our show wherever you get your podcasts.